अब हमारी ना सिंधी में एक कहावत है, सिंधी की कहावत बताती हूँ पहले। कारो कारे जस रंग संग रहे, रंग न मटाए आदत मटाए। यानी जब काला काले के साथ रहता है, रंग भली ना मिटाए, आदत बता। तो मैं आपके साथ रह के शायद स्ट्रिक्ट हो गई। So I'm going to speak about adolescent endometriosis. How many cases I have seen, and I have done laparoscopy. I have not done laparoscopy for a single patient, right? I'll be honest. No, that's not a credit for me. So I had 3 patients. When I prepared this presentation, I realized where I was wrong, and I'll be talking about all those patients in my presentation. And you'll be surprised, when I was reviewing the literature, Renu Chawla was telling me, Madam, आपको क्या prepare करने की ज़रूरत है? आप ऐसे ही बोल दो. But when I read a topic, I go through the cross references. So I came across 2 people, Redwin and Borson. So Borson has done work in 1983, and Redwin has done work somewhere 1990. They had those primitive cameras, and they had, same knowledge that adolescent endometriosis is a disease, and they have done laparoscopy, and from their cameras they have taken those pictures which are in Elsevier's journals. I did not take those because the camera at that time was very primitive. But I must salute to them, and we don't honor these people, And after 20, 30 years now, we have suddenly, woken up that there is a endometriosis in adolescent also. So when we say adolescent endometriosis, which age group we are talking? The age, adolescent definition could be different. But ASHRAE says, girls and young women who are under the age of 20, you should call them when we are dealing with endometriosis, these are the women we say they have adolescent endometriosis. But other, journals, they have taken less than 22 years. So any patient less than 22 years, if she has endometriosis, we'll say adolescent endometriosis. So here's a patient, and this is a true patient, and I still repent about this patient. She was 18-year-old, and she came to my OPD. She was brought by my senior resident. She was complaining of pain in lower abdomen for past 2 years. This all started after her mother died. This she told me. So which, made me think, is it a psychological thing? In the last 6 months, she had to be rushed to emergency for injectable analgesics. She has been missing her college off and on. She wasn't sexually active. She had no urinary problem. Her urine culture was fine. Ultrasound abdomen and pelvis was done twice, which showed nothing, because radiologists are not aware what are the signs of endometriosis in adolescent. MRI pelvis was advised, but she got shit scared, when she reached the MRI, she didn't want to go inside and she didn't get it done. She was on NSAIDs and OCPs, not much relief. She was referred to a gastroenterologist who advised her endoscopy, because every time she had pain, she was having vomitings. And she didn't get it done. Ultimately, I referred her for the to the pain management clinic, and then I lost her to follow up. This patient, when I think retrospectively, I thought I should have offered her laparoscopy. But she only had, pain, and she had nausea, and this was unrelated to her periods. So we'll be coming to that in my next few slides. So now the question is, what is the prevalence of endometriosis in this age group? So the incidence of endometriosis in adolescent, defined as girls, below the age of 20 years with chronic pelvic pain, is reported to ranging from 25 to 73%. So 25 to 73%, it is not in all population. In all those adolescents who come to you with chronic pelvic pain, there the incidence is high. The true disease prevalence in general adolescent population, we do not know how much it is. So if you see, so in adolescent with chronic pelvic pain, the incidence is 25 to 49%. But if you see those adolescents who are not responding to medical therapy, the incidence is as high as 50 to 75%. And if you see ultrasound, in ovarian endometrioma will be seen only in 11% cases. There will be other soft markers which you have to be aware, and which your radiologist have to be aware. In 5.2% adenomyosis, and DI is seen only in 3.7% cases. What is the prevalence if you do the laparoscopy? So this Jensen, he published his case series of adolescent patients where he done the laparoscopy, and he said the incidence varies from 19 to 43%. And again, those who are, patients who have just chronic pelvic pain, it is 75%. But those who have a chronic pelvic pain which is resistant to medical therapy, it is as high as 75%. Alone dysmenorrhea, the incidence is 49%. But whenever you are taking patient for laparoscopy, you have to tell her that there are only 2/3 chances that I'll find endometriosis. The possibility that in 1/3 patients you may not find anything. So patient should be prepared for that. It should not come to her as a shock. I underwent a surgery and nothing has come out. We all know the risk factors for endometriosis. They are same. Early menarche, first degree relatives with endometriosis, any patient who has a history of asthma, migraine, or she has a congenital anomaly in her uterus. What will be the clinical findings in these young adolescent girls? We all know dysmenorrhea is normal. So whenever any patient comes to our clinic and she says, I have severe menstrual pain, we simply brush her off, wash her off. It's a dysmenorrhea, normal thing. Don't worry, do exercise, NSAIDs, and drink plenty of water and whatnot, But the symptoms of cyclical pain was present by itself only in 9.4% of subjects. 28.1% of subjects, they had acyclical pain in this series of Devasta. And in 62.5% patients, they had both cyclical and acyclical pain. That means in nutshell, 90.6% of adolescents, they will have acyclical pain. So any adolescent who comes to you with a complaint of pain abdomen, has been going recurrently to emergencies and no solution has been found, think about endometriosis. This pain may not be in the lower abdomen, it could be even in the upper abdomen. And why in the upper abdomen? I'll be explaining in my further slides. Nausea in combination with pelvic pain should perhaps be considered a marker to raise suspicion for endometriosis in adolescent. In one of these Chinese studies, what they found that 29% had acute abdominal pain, some GI symptoms, irregular menses. They also saw few patients who had intermenstrual spotting, and dyspareunia was seen in 1.5% cases. So there is a delay of 7 to 10 years, right, in a diagnosis of endometriosis in adults. In these young girls also there is a delay of 20 months or so. So what happens when they are suffering from this constant pain throughout? So because of this constant pain, what happens to them? It leads to hyperalgesia, central sensitization, and mood symptoms. That means this patient will tell you that I have a lot of anxiety, I'm always fatigued, I'm tired. That is because of the constant chronic pain. And then these patients, they will also say that I'm having pain in my groin, in my sacrum, and this pain is like cutting, and all this indicates that now this patient has developed neuropathy because of the constant pain. So just don't think that what she is talking is nonsense. One has to apply the mind. No, it cannot be endometriosis alone. It could be any musculoskeletal disease also which you have to rule out. So according to Ashray, in adolescent, clinicians should take a careful history and consider the following symptoms suggestive of presence of endometriosis, and these are chronic or acyclical pelvic pain, particularly combined with nausea, dysmenorrhea, dyschezia, dysuria, dyspareunia, or cyclical pelvic pain. So whereas in adults, we take dysmenorrhea as one of the leading symptom, in adolescent it could have a atypical presentation. Clinical examination is not very helpful because majority of these young girls, they are not sexually active and if they allow, you can do PR or PV, but you may not find anything because these patients, they have early disease which may not be, you may not be able to detect by any of these clinical examination. But when you are doing clinical examination, rule out that you are not dealing with some joint problem or something. So just don't restrict your hand on abdomen. Just tell her to move her legs. Is it a hip pain? Is it something in the thigh? Because otherwise we'll have just a very narrow focus vision. It's only endometriosis. What ultrasound? So they have earlier stages of disease. Earlier stages means ASRM class 1 and 2, where they're just adhesions, right? And may not have any endometrioma at all, may not have DIE. So what will ultrasound tell you? So if the ultrasound says it is negative, no. You have to go and speak to your radiologist regarding what? So they have earlier stages of disease with smaller endometriotic lesion, which could be difficult to detect using ultrasonography. for small, and suppose if the radiologist says that she has a 10 millimeter endometrioma. Now don't just think that it is endometrioma. It could be just a hemorrhagic cyst. Call her after 3 months, repeat an ultrasound. By that time it would have disappeared. There are indirect sonographic signs are soft markers. Now, I was going through the literature, what I found, people are not interested in doing research. Like when I was really looking, studies, where they have taken OCPs for adolescent endometriosis or, progestins, no. But you will find plenty of systemic reviews and meta-analysis on small 1 or 2 studies. So this particular, it's a very good, review which has been published, and everybody, so many citation. So he had written, there are soft markers for endometriosis. I was very excited, But I went to the original article. So these soft markers are for any pathology. They are not specific for the endometriosis. What are these? Site-specific tenderness and reduced ovarian mobility. They are correlated with the endometriosis, but they could also be there in PID. They could be there in any other pathology. But if these two are there with your clinical suspicion, then you can think of that probably she has endometriosis. So ovarian mobility as a sonographic soft marker of DIE, it performs better when there is a endometrioma. If there is no endometrioma and there is just ovarian immobility, it may not be endometriosis. Adhesion may be suspected if ovaries or the uterus, they move together with the adjacent structures such as bladder, intestine, pouch of Douglas and parietal peritoneum. What we say, the sonographer is palpating the abdomen, but you have to sensitize your radiologist for all these things, because majority of radiologists don't read. They are not aware of all these things. So small deep infiltrating endometriosis nodule may be easier to identify by the tenderness guided TVS sonography. But here, on a gel, on a vaginal probe, normally you take 4 ml gel, you put extra gel, then only you will be able to see this. And if your ultrasound is negative, it does not rule out endometriosis. So this is the article from 1987, and I thought it's really good. It tells us the why we are not seeing anything, because he says the glandular element themselves are usually quite small, and frequently the color seen at surgery is due to fibrosis, giving rise to many of white or yellow color. Endometriosis does not have any color, or if there is a hemorrhage, then it will become red. So if endometriotic glands are like those of native endometrium, they do not secrete blood. Human tissue or spaces that lack blood are typically clear at white. So that's why adolescent endometriosis, you only see clear white lesions. This guy, Metalossi, he et al. Reported that during laparoscopic examination, 81.8% were diagnosed with endometriosis stage 1 and 2. And 18.2% they were diagnosed with stage 3 and 4. So majority patients are stage 1 and 2. And ovarian endometrium are only observed in women who are more than, majority times, 20 years, right? It is not a rule, but this is what he had observed. So here's a picture, and this is from the old cameras. That's why, it's like this. And this guy, Redwin, he said, I do not know whether you can appreciate these red lesions, can you? Yeah. So he said red lesion consisting of red flame-like areas, red vesicles and red polyps. These lesions are composed histologically of endometrial glands, a highly vascularized stroma and focal hemorrhage. And these red endometriotic lesions, they secrete PGF2. Because they secrete PGF2, that's why patient comes back to you with the bowel complaint and that, acyclical uterine pain. So in 1987, he gave us this information and we sat over it, And according to this guy, Gordon, he said the most frequent sites involved included the posterior cul-de-sac, uterosacral ligament, peritoneal pockets, respectively. And infiltrating endometriosis, which are more than 3 to 5 millimeter, they occur below the level of ureter. Above the level of ureter, you will not find them. The peritoneum of cul-de-sac was most common site of typical and red lesion. Cul-de-sac lesions rarely penetrate directly into subperitoneal fatty tissue in the central cul-de-sac, right? That means rectum is not involved. And when found in the lateral margin of cul-de-sac, both typical red lesions were often extension of infiltrating implants in the contiguous ligament tissue. That means you will find red white lesion in the pouch of Douglas, deep infiltrating lesion below the level of ureter. That's the nutshell. Now here is a patient. Again, this article is also very old. I don't know. 1993, Gordon has done this work. And if you can see this peritoneal defect, so here is a peritoneal pocket. If you biopsy not the periphery but the deepmost part, and you subject it to histopathology, you will find endometrium glands. And this was the patient who was suffering from radiating pain to the back and legs with the menses. Now these pictures are much more clearer because they are taken now recently when we have high definition cameras, etc. So typically you will find red and clear peritoneal lesions like this. Here you can see are just clear blebs like this. So you really have to pay attention. If you are in a hurry, I have to go to this next case, you are not doing justice to that patient. Give time. These superficial peritoneal lesions are reported to be highly inflammatory. Moreover, it has been shown that clear and red lesions, they are the most painful. Now, these are also from the current listing. So here you can see, a peritoneal defect. And this was a 16-year-old patient who had a stage 2 endometriosis. And if you see here, I can't see, here. These are the red vesicles, and here these are the white fibrosis, and here is the ureter. So that's why when you are doing surgery for endometriosis and you want to do ablation, coagulation or excision of peritoneum, the first dictum is dissect ureter. If you are not dissecting ureter, don't do surgery, because ureter is a danger. Suppose, just think, here is the fibrosis. Can you see this white? And here is the ureter, right? Just underneath it. And you do coagulation, you burn the ureter. So poor 16, 17, 18 year-old girl, and she's in trouble. And here is a 15-year-old girl who had a stage 3 endometriosis, and you can see these, lesions. They are little darker. And here is a 18-year-old girl. You can see these clear blebs. They are so tiny that if you don't pay attention, you may miss out. Now this is very evident, but this girl was only 15-year-old. You can see, here she might be having deep, because whenever you see endometriosis on the uterosacral, you have to think it has to go down. It has to be deep infiltrating endometriosis. Now, she had stage 3 disease. And here is a hemorrhagic red lesion in a 20-year-old patient. She had stage 2 endometriosis. So early stage lesions are difficult to detect even under laparoscopy. So this was the study by Laufer, because what he says that you are distending the abdomen with carbon dioxide. So these micro vascularization and flimsy adhesion you may miss out. So he said fill up the peritoneal cavity pelvis with the saline, and now you put your scope in it, and then you try to visualize, you'll be able to see it. But I really went through his original article, but I could not find any video or any pictures. So, but everybody has quoted him. So question is, when should you do laparoscopy, right? Every patient who comes to you with a cyclical pain, you should do, or when? So Esche says that in adolescents with suspected endometriosis, where imaging is negative, majority of cases imaging will be negative, right? And medical treatment with NSAIDs and hormonal contraceptive have not been successful. Now is the time for you to do diagnostic laparoscopy, so that you don't waste patients' time, and you should think of some other specialty also. But in 2/3 cases, you will find endometriosis. And when you are doing diagnostic laparoscopy, don't just do the diagnostic, you have to do surgical at the same time. So data in adolescents show that nearly 2/3 of adolescents who have chronic pelvic pain, there will be laparoscopic evidence of endometriosis. And but when you are taking the patient for laparoscopy, you have to talk to the patient. There is a risk of anesthesia, risk of surgery, plus you will be causing scarring, and she may have recurrence later. Is it really worth it? So just weigh it down. When you are able to confirm the diagnosis through the history and through examination or maybe ultrasound finding, you don't have to do diagnostic laparoscopy. Without histopathological confirmation, you can start the treatment. We all are aware of this. And clinicians should be aware that all forms of endometriosis have been found in adolescent. although some reports suggest that peritoneal endometriosis in adolescent may have the atypical appearance. So as I said, if you are doing a laparoscopy, if there are, peritoneal defects, excise it, coagulate it. If you are laser, ablate it. So you have to treat it at the first time. Now there are cases, case reports of premenarchal endometriosis. Premenarchal endometriosis means these are the two, Marsh et al. He has reported 5 patients ranging from 8.5 to 13 years. They had breast development, tenor stage 1 to 3, chronic pelvic pain lasting for 6 months. And when he did a laparoscopy, he found, red clear peritoneal endometriotic lesions. They were observed in all 5 adolescents. So even if a premenarchal girl comes, right, think about it. And Albert also reported about this 9-year-old girl. She had breast development. She started having period 1 year after it was confirmed that she has endometriosis. So, and both these case reports have shown that none of these girls had some congenital malformation of uterus to say that, that's why they are having. And how we explain this? Because it's not only the retrograde menstrual theory, it is the stem cell theory, metaplasia, because now we say that there is a embryonic development of endometriosis, or epigenetic theory of endometriosis. So should diagnosis of endometriosis in adolescent be confirmed by histology? So this one study, what they did, they did a laparoscopy, and in laparoscopy they took biopsies wherever they had found vesicles or red lesions, and they found that in 93% cases it was confirmed histopathology. So by confirmed histopathology of endometriosis. So based on this, ASHRAE says if a laparoscopy is performed, clinician should consider taking biopsies to confirm the diagnosis. Otherwise, if the histology is negative, you cannot say it is not endometriosis. Still treat if you're suspecting. Now, what is the best treatment for adolescent with suspected endometriosis? We all jump to Meftal and NSAIDs, but ASHRAE says that consider NSAIDs as treatment for endometriosis associated pain, especially if the first line hormonal treatment is not an option. So according to ASHRAE guidelines, first line is hormonal. If that is not an option, then you can, but I know when you are treating clinically, you may give, oral contraceptive pills. First cycle she may not respond, second cycle she may not respond. Add NSAIDs, make her comfortable. Regarding NSAIDs, they say that first thing you give the typically double the dose, and then the normal dosage, and continue till her pain is better. And ACOG guidelines say that NSAIDs, if you have to give for pain, then when patient is having cyclical pain and you are suspecting endometriosis, start it 1 or 2 days before she has actually started her periods. Then only it will work, not otherwise. So here's a single study which I found, where they had taken compared, oral contraceptive pills which had only 20 microgram low dosage OCPs vis-a-vis placebos. So what did this show? In adolescents with severe dysmenorrhea or endometriosis associated pain, clinicians should prescribe oral contraceptive pills or progestins or LNGIS as the first hormonal therapy. This is ASHRAE says. But this guy, Rachel Davis, I forgot to write that, he had shown that the effect starts in the 3rd cycle and OCPs are better than the placebos. So we should try any OCP. No, not necessarily Dynogest containing OCP, any OCP will work. And ASHRAE says that yes, you can give, OCPs, progesterone, LNG-IUS as first line hormone therapy because they may be effective and safe. However, it is important to note that some progestins may decrease the bone mineral density, and we'll talk about it later. Should you use continuous or cyclical OCP? We all jump continuous. So here I found very good study by this guy, and he had one group of patients for 6 months. He gave continuous OCP, continuous cyclical, no withdrawal. Only when patient was having slight bleeding, then he would stop it. Other group, he regular the way we give. And what did he find? He said both regime of OCP are effective in treatment of primary dysmenorrhea. Continuous OCP outperforms cyclical OCP in the short term, but after 6 months, this difference is same. So even if you are giving cyclical OCP by 6, you have to just tell the patient, wait, take NSAIDs, you will be fine. But we should know that 33% of patients given estrogen progestins or progestins do not respond to the therapy. What is the role of progestin? So, honestly speaking, I really searched, there are lots of papers, but progestin alone in adolescent endometriosis, I could not find much paper. So whatever I could take, from those reviews, maybe I did not search it properly. So according to them, progestin only methods include mini-pill, norethindrone only. That means you can use any progesterone only pill which we give for the lactation. These are in the US, norethindrone only pill and norethindrone acetate. We have norethindrone is Primulate and norethindrone acetate is Regestrone, right? So importance of norethindrone acetate is that it's a long acting, so you have to give it twice in a day, and norethindrone is short acting, so you have to give thrice in a day. So Primulate we give thrice and Regestrone we give twice. But norethindrone acetate gets converted into ethinyl estradiol in the body. So some amount of estrogen is still going there. And norethindrone acetate has been shown to be effective treatment of endometriosis and tolerated by most adolescents. Medroxyprogesterone acetate, the dosage which I came across, 30 milligram, tablet is 5 or 10 milligram. Which patient will be able to tolerate 30 or 50 milligram? That's the dosage which they have used. It can be used, that is administered every 3 months, intramuscular, subcutaneous form or oral. So progestin only therapy has side effects like irregular bleeding, weight gain, emotional liability. Patient really gets crying spell because of the depression, constant progesterone. So providers should first consider oral progesterone, because in case patient has symptoms, side effects, you can stop it. Injectable progesterone, you'll have to wait. And with injectable progesterone, patient will lose the bone density. Until the age of 17 years, patient is the bone is forming, it's accruing. So what is the role of Dynogest, right? Bone mineral density had fallen by minus 1.2%. They again followed up these patients, and after 6 months, there was partial recovery in lumbar bone mineral density. So whenever you are pushed in the corner and you want to use this Dynogest in girls who are younger than 17, think twice. I had met, Romero, he's done a lot of work on Dynogest in one of the meetings, in India only. And he says, he's from Germany. You will read his papers. He said, Dr. Khemani, I don't use Dynogest in these young girls. My first preference is OCPs. This is another study, So this is the same study. The first part was that bone mineral density had fallen, but mean endometriosis associated pain score, which was 64 to begin with, it had fallen to 9. So it's very effective in reducing the pain. Because bone accretion is critical during adolescent, result of the Busan study to assess safety in adolescent study highlighted the need for tailoring treatment in this population, taking into account the expected efficacy on endometriosis associated pain and individual's risk factor for osteoporosis. If the girl is thin, she has a family history of osteoporosis, don't even think of starting Bisane, Dynogest. But if she is really overweight and no family history, athletic, you can still think of. So individualize your patient. And how does Dynogest work, right? And this does not fit here, but I just put it here because how much people investigate. So what this guy did, one group, he did chocolate cystectomy and subjected to histopathology, and these patients had not received any Dynogest. And other group who had received Dynogest, and he did cystectomy and subjected to histopathology, both the cyst fall. What did he find? He found that there's a deserialization was significantly more in the Dynogest group. Obviously, it's going to cause the deserialization, and there was a slightly decreased inflammation. There was no significant difference was observed between two groups in terms of necrosis, glandular atrophy, and angiogenesis. So Dynogest basically works by creating a stage of deserialization and by reducing the inflammation. So here, this study is published in 2023. So not only pain score this particular person he studied, but also the mental state of the girl, the emotional state of the girl. So what they gave Dynogest for 1 year, and the age group was again 13 to 17. So what did they find? The therapy provides a significant elevation of endometriosis associated clinical symptoms, including dysmenorrhea, pelvic pain, GI symptoms, dysuria, decreased and also there was a decrease in anxiety, depression score, and quality of life had improved. So that is the advantage of Dynogest when you are using it. And this study was really extensive. They measured prolactin, estradiol. Estradiol is a marker of inflammation. CA125, neutrophil lymphocytic ratio. So these effects were accompanied by beneficial dynamics in hormone and inflammatory markers when you are giving Dynogest, right? A low body mass index with high C-reactive protein levels were associated with a higher VAS score. That means they were measuring C-reactive protein in every patient. So they found, those patients who were really thin and they had a high CRP, they had a higher VAS score, and high estradiol level was also a factor for anxiety and depression aggravation. So we have talked about estrogen, progesterone, and we have talked about plain progesterone. So what is the role of GnRH analog? Where does it fit? We all know these girls are young girls, their bones are forming. Should you be using GnRH analog at all or no? What does ASHRAE says? So ASHRAE says in adolescent with laparoscopically confirmed endometriosis and associated pain where your hormonal contraceptives have not worked, progesterones have not worked, here you can prescribe them GnRH analog for 1 year, but with add-back therapy. Don't give them without add-back therapy. And the GDG recommends that in young women and adolescent, if GnRH agonist treatment is considered, it should be used only after you have discussed pros and cons with the patient. What are the advantages? What are the disadvantages? So which add-back therapy you will use? So here is a study where in one group they gave 0.625 ethinyl conjugated equine estrogen along with the norethindrone, and other group they gave the plain norethindrone, thinking that it both should work as a good but what was found that after 1 year of treatment, adolescents using GnRH agonist and combined add-back therapy had a better quality of life as compared to adolescents who were using GnRH agonist with the add-back of norethindrone only. So if you are giving GnRH analog in these young adolescents, don't forget to add 0.625 of ethinyl estradiol and norethindrone. Do not combine oral contraceptive pills as a add-back therapy, because it will negate the effect of, because what will oral contraceptive pills do? Suppression of everything, and estrogen already is low, and plus the ethinyl estradiol which you are using, the dosage in OCP is 4 to 6 times higher than the conjugated equine estrogen. So where does LNG IUD fit? So there is a limited but consistent evidence that LNG IUD reduces dysmenorrhea in adult and adolescents. I did not find any study where they have used LNG IUS in adolescents with endometriosis. This is only in those patients who have dysmenorrhea where they have used, and we are extrapolating it. The systemic level of hormone from the LNG IUS may not be high enough to successfully suppress endometriosis associated pain, right? So therefore this particular author, what they said, that you do a laparoscopy, you remove all the lesions, and after that at the same time put an LNG IUS, because you have to give something. So that's where it works best. So once you have done the surgery, and after that, should you continue them on oral contraceptive pills or Dynogest or whatever? Is there any recurrence in these young adolescent girls? So they, followed up these young girls in this particular study for 10 years, and they had to do re-laparoscopy in some patients within these 2 to 10 years. And what did they find? That whatever stage they had operated at the first surgery, at second stage surgery also the stage was same, right? And all these girls were on these hormones, contraceptive pill or whatever it is. So what did they conclude? They said medical therapy should be continued until fertility is no longer desired and family size is complete. So if you have done a laparoscopy, you have burned, excised, please put the patient on therapy till she is married, till she has children. And what do ASHRAE guidelines says? In adolescent with endometriosis, Clinician may consider surgical removal of endometriotic lesion to manage endometriosis related symptoms. However, symptoms recurrence rate may be considerable, especially when surgery is not followed by hormonal treatment. So they also endorse that do surgery and after that give them some hormone, put LNG IUD. If the surgical treatment is indicated in adolescents with endometriosis, it should be performed laparoscopically by an experienced surgeon who has an experience of it, because otherwise you may miss out and you may say that you have nothing. And so, because these girls, they are suffering from pain, they are running from here to there. So all kind of, therapies, Chinese therapy. So here is one proof, which this thing is special thing which I found. So I thought I must mention it. And this is in a very current journal. So what they say, we also identified Japanese style acupuncture to be safe, effective and very well tolerated adjunct therapy for adolescent endometriosis through a randomized sham control trial. Not available in India. I don't know much about it, right? Thank you.